Okay, folks, I would like to start this whole thing off by introducing Dr. Cathy Craven, who is the director of, I think it's rehab medicine at University of Toronto, and Anita Kaiser, who is a research associate with Cathy, I'm pretty sure, in the SCI Mobility Lab. Are those correct?
I'm with Dr. Craven's lab as well as the SCI Mobility Lab, so both.
Okay.
Osteoporosis.
And they have done this presentation before, and as you can see, at one point it was a podcast. So I asked them if they would do it for us, and they were very graciously agreed. No problem at all. They're in Ontario, so they're in a different time zone than us, but agreed to go this time with us too. So I would like to, I think Anita is going to be starting us, and Cathy is there on your screen. You can see her probably. And I'll let them get going, and we'll hold questions till the end. And I did forward the questions that we developed at our discussion group 2 weeks ago. So they got back to me and said that they could probably address those in the presentation, but we'll see. And there'll be room for questions afterwards. So with that, I will turn it over to Anita. Thank you.
Thank you, Duncan. And thank you for inviting Dr. Craven and I over here to talk to everyone about bone health after spinal cord injury. We will be sharing this information through a podcast series that we did co-design called the Bare Bones Podcast. So I'll start first with just some brief disclosures. I have no conflicts to report. However, I am a board member with CSRO, as well as a committee member with NASCIC and the Canadian ABT Community Practice. And Dr. Craven holds a number of research grants and awards from various organizations. She's also the chair of the Canadian SCI Rehabilitation Association, a board member with the Ontario Sports Support Unit, as well as the PVA panel chair for the Bone Health and Osteoporosis Management Guidelines. So we have 4 key objectives for this talk. The first is to define the process for people with lived experience of SCI or PLEX and their family caregivers to engage with the PVA Bone Health Clinical Practice Guideline content, as well as to recognize the structure and intended use of the Bare Bones podcast series and education action tools, and discuss a case-based scenario regarding the use of non-drug therapy for treatment of low bone mass and osteoporosis and moderate to high fracture risk after a spinal cord injury. And then finally, to review the findings from one podcast episode and the related EAT, which is a handout relevant to the case discussion. I think before I go further, I just want to remind everyone to mute yourselves if you haven't already done that, and that way there's no interference during the talk. Thank you. Okay, so everyone should be in the business of fracture prevention. And I think what's important to note is that we don't typically see fractures of the forearm, spine, or hips in people with SCI. And if you look at the image on the right, you can see the 3 common sites for fracture, which is both above and below the knee. And so if you do notice any signs of or symptoms of swelling, redness, bruising, and you get pain or maybe symptoms of autonomic dysreflexia, it's really important that you get checked for a possible fracture. So why do we care about fractures? Well, we care because fractures can lead to complications such as blood clots, pressure injuries. It can lead to depression. The bones may not heal properly, or it may take a very long time to heal. And this can actually lead to a loss in your mobility, as well as your independence and activities of daily living. You may need to increase your hours of attendant care as well as a result, and it could also increase the risk of mortality. Kim Eggert, do you mind just muting your microphone, please?
Oh, sorry, yes.
So in order to provide the best available care to people with spinal cord injuries, Dr. Craven teamed up with 14 other experts in the field, and together they produced the clinical practice guidelines for bone health and osteoporosis management. And so to do this, they did an extensive review of the literature, and then they assessed each of the relevant articles for the strength of its evidence. And in the end, they came up with 64 recommendations. And so the CPG guidelines are divided into 8 topics, and you can see the the diagram on the right, how those 8 topics and the concepts relate to one another. And so these guidelines is actually a great guide and tool for your healthcare team to learn about bone health and how to help you to manage your bone health. And there's a process that should really be started early on after a spinal cord injury, and most especially if you've suffered a fracture. And so we do encourage you to let your healthcare team and your family physician know that these guidelines do exist and how to access and get a copy of them. And so, like I said, the PVA guidelines was developed for clinicians, but what we wanted to do is really try to bridge that gap and provide that information and content within the guidelines into a clear and simple format for the SCI community to be able to understand, act, and adhere to the guidelines. And so what we did was we developed a podcast series to ensure that the SCI community would understand the guideline content and how to act to reduce their fracture risk. Each of the episodes is based on one chapter of the guideline. And in all this, although the podcast was designed specifically for the SCI community, your healthcare team may actually also find it of use and benefit to them as well. So like I said, there's 9 episodes in this podcast series. They run about 8 to 15 minutes in length. Each of them have a corresponding handout or EAT, like I said, which provides a summary of each of the episodes. And you can see the 9 episodes listed here in the diagram. The titles that are in blue represents the title for each of the podcast episodes. And the title below it in black is the corresponding title that links to the chapter within the guidelines. So we do actually recommend listening to the podcast series in order, but you could choose to listen to specific episodes only, or once you've listened to the whole thing, you can always go back at any time and re-listen to specific episodes if you wanted a refresh in that information that was provided. So now I just want to briefly go over the process that we used to develop the guidelines, because like I said, it was a co-design approach. So our team did include people with lived experience of spinal cord injury. So to start off at the beginning, all the way over on A here, our team got together to identify the titles for each of the episodes, as well as an opening tagline to really try and hook our audience in and give them something to sort of think about right off the start. Then myself and 2 other individuals with spinal cord injury sat down and we actually went through each of the chapters of the guidelines, and we created a set of questions that we felt were need to know information for the community. Once we did that, we invited each of our guest speakers, and each of these speakers were actually authors on the guidelines, so they were experts in the field. And we invited them to an orientation session where we went through the list of questions that we were going to ask them at the podcast, and also went over the responses to make sure that the responses were provided in a clear and simple format for the community to understand and follow along. Once that was finalized, we recorded each of the episodes. So each episode contained 2 hosts that each had lived experience of SCI, as well as 1 or 2 of the guest speakers who were the chapter guideline authors. Following the recording, each of the episodes went through sound editing and mixing, and then each of these podcasts were then used to create our educational handout tools, which, like I said, provided basically an overall summary of each of the podcast episodes. So following that, and I'm all the way over here at H&I, we went through a very iterative process of reviewing each of the podcast episodes as well as the handouts for flow and clarity and accuracy, first within our research team and then with the community at large through focus group interviews. And then we use the feedback obtained from that those sessions to revise the podcast and the educational handout tools further. And once we had our finalized product, it was ready for dissemination, which we have posted on our website, www.scifragments.ca. So now I want to walk you through a case study so you can see how the podcast can be used, as well as the handouts can be used to really help you to take charge of your health. So I'd like you to meet Jordan. Jordan is a 36-year-old male with a T8-HA paraplegia secondary to a motor vehicle accident in the last 3 weeks. Prior to his injury, he enjoyed playing pickup basketball once a week and rode his bike 2 times per week. Jordan would like to discuss non-drug therapies for the treatment of sublesional osteoporosis. So what do you advise? And I know you haven't gone through any of this information yet, but just based on your own knowledge or feedback, if you like, you're welcome to type in your responses in the chat if it's available. This information for this case study can be found on episode 6, Get Moving and Loading, which is found at the link below on our website, or also the QR code. But I will be playing a short clip of that episode just so you can get an idea and a sense of what the episodes all sound like. But before I do that, I just want to give you sort of navigate you through what you would see if you log into our website and you go to one of the episodes. You're going to see a page that looks like this. And at the top here, you can see the options to click on to access a podcast episode, either in a video or audio format. And below that is the links to get the handouts. And then below that is a button to provide feedback, because we always love to learn about ways we can continue to learn, grow, and improve. And when you click on the handout button, you'll see this is basically what one of our handouts look like. As I said, the handout basically provides a summary of each of the episodes. And you can see at the top, this is the title of the episode that the handout relates to. Below that is a key concept as well as a fun fact. In the middle section, we have the basic background information that you can actually print this handout out, take it to your healthcare team or family doctor, and use it to review and discuss your health with them. Below that is an action item that lists things that you can do after reading, as well as a take-home message below that. And then below is just the sources of funding. Okay, so I will now play a short clip of the podcast for you, and you can think about what you're thinking about regarding what you advise.
Did you know that weight-bearing exercises like standing and electrical stimulation may increase bone health following a spinal cord injury? Hi, my name is Anita Kaiser.
So I'm just going to stop for a sec. Can you all hear it?
Yes.
Okay, perfect.
And this is episode 6 of the Bare Bones podcast, Get Moving and Loading, where we'll talk about therapies to improve bone health. Joining me is my colleague, Wendy Murphy, who has over 30 years of experience living with a spinal cord injury, and our guest, Dr. Therese Johnson, a professor in the Department of Physical Therapy at Arcadia University in Pennsylvania, and Dr. Christine Cowley, an associate professor and director of the Spinal Cord Research Center at the University of Manitoba. Welcome to the show, Dr. Johnson and Dr. Cowley.
Thanks for having me. Thanks for having me also.
I'll begin with you, Dr. Cowley. For people living with spinal cord injury, especially those of us who already have low bone density, are there exercises or activities that we can do to prevent or treat low bone mass and osteoporosis?
The short answer is yes. Although there are limits to what we can expect to gain from these exercises, which are dependent upon how long you are in your journey sustaining a spinal cord injury, activities like passive standing or electrical stimulation-based therapies can assist in terms of slowing down rate of bone mineral density loss. Depending on the time point post-injury, even people who have sustained significant bone mineral density loss can use therapies such as electrical stimulation-based therapy to improve their bone mineral density status.
For the many listening, and in general terms, can you explain how these therapies work, Doctor?
Yes, in a nutshell, the regulation of bone density is very much like every other system in our bodies. If we don't use it, we lose it. And people who exercise more have stronger hearts, larger muscles, and typically stronger bones. The difference between bones and other organs and tissues in the body is that bone is very, very slow to improve its density once we become adults. So we don't see changes as quickly as we do than when we're doing other forms of exercise. Say, for example, strength training, where we can easily see increases in muscle mass over the course of a few weeks or months. So basically for bone, there's three types of forces. Those that are caused simply by gravity acting on the long bones of the legs when we stand upright, which are called compressive forces, or compressive loading. And then there are those that are generated by muscle contractions acting through tendons on bone. And these could cause torsion or twisting forces, as well as bending forces. And additionally, the action of two muscles that are antagonists to each other, say, for example, your quadricep extensors and your hamstrings, which both act on the knee, when stimulated together, can form a compressive load on bone as well. So if the bone receives signals of these types of physical loading, it responds by changing the balance between bone resorption and bone formation, such that bone formation is favored over bone resorption or bone loss, and therefore it tends to increase bone mineral density. Loading can also slow down the rate of bone resorption, such that you may not improve or increase your bone mineral density, but you might slow down the rate at which your bone mineral density loss occurs.
Thank you, Dr. Callie, for explaining how that works.
Okay, so I'll stop it there. And
These activities.
And I'll pass it over to Dr. Craven. Hopefully you learned a little bit and compared it to what you originally thought. And I'll let Dr. Craven cover some of the key concepts.
All right, has anybody ever heard about FES or passive standing in a standing frame or long leg braces and forearm crutches before today? Okay, when we talk about the Get Moving and Loading chapter, as well as the chapters looking at calcium, vitamin D, and drug therapy, we use two terms, one prevention and the other treatment. Prevention is when we find people who have normal bone mineral density at the time of injury onset and who are at risk of developing low bone mineral density due to spinal cord related bone loss, which in someone who is motor complete typically happens at a rate of 3 to 5% per month for the first 2 years after injury. It's very dramatic bone loss, much more than women experience at menopause. And treatment is for those people who have established low bone mineral density and increased fracture risk. So if you are someone who had your injury, in your 30s or 40s, it's very likely you had normal bone mineral density at the time of your injury, whereas some people who had their injury onset, after the age of 60, where they've already experienced menopause or age-related declines in bone mineral density, might have low bone mineral density right from the time of injury onset. So we talk about two groups. Prevention, that's the group we want to turn off bone loss before it occurs. And the group who have low bone mass and high fracture risk that we want to try to prevent fractures. So you'll hear those terms prevention and treatment throughout the CPG, but I want to make sure that everyone understands that. Is that clear to everybody? Debbie, did you have a question?
No, I was going to say yes for everybody, but I can't speak for everybody.
Okay, thank you. All right, next slide. So in the new, in 2019, the International Society of Clinical Densitometry put out for the first time a position statement on bone mineral density screening for people with spinal cord injury. So there's actually guidelines about how and when to test people's bone mineral density. And position 4 is a really important one for you to be aware of, particularly for people with chronic injury who may have low bone density and high fracture risk and may not be aware that before you participate in some of these exercises we're going to talk about, you need to have a therapist or a practitioner review with you your risk factor for fracture. So that you know whether you have a low, moderate, or high risk of fracture when you participate in an activity. There is really no bone mineral density value below which weight-bearing exercises are absolutely contraindicated. Some people with high bone density get fractures, some people with low bone density get fractures, but more often the people with low bone density get fractures. And Those people who have had prior fracture or we know have low knee region BMD are most at risk for fracture. So that's what we call the big two risk factors that we want people to know about. We also want to know if you have any range of motion limitations like a hip flexion contracture, knee flexion contracture. If you don't have the same ankle range of motion as you used to before you get to do some of the weight-bearing exercises. So you want someone to talk to you about your risk factors for fracture, check out your lower extremity range of motion and alignment. And for those people who are going to participate in weight-bearing therapies, such as using an exoskeleton or a body weight support treadmill, has anybody in the room used those before? We're suggesting that those people should probably have an X-ray of their foot, heel, and ankle before, just to make sure that you don't have a prior fracture. If you have a prior fracture that you didn't know about, that would make participation just a bit riskier for you. It doesn't mean you shouldn't do it. But the analogy that I use when I try to explain to clinicians is, you can drive a BMW or you can drive a motorcycle. People understand the risk being involved in different activities when you drive. It's the same thing using rehab therapies. We just want you to have reviewed your risk and understand it when you're signing up for activities. So if you are thinking about starting some of these therapies we're talking about today, you want to make sure you reviewed your fracture risk and your lower extremity range of motion and alignment with your therapist before starting. Is that clear? And this is all in the fourth position of the ISCD position statement, which is widely available. It's open access. And if your therapist or team is not familiar with it, you can always show it to them. Okay, next slide. These are the common risk factors for fracture after spinal cord injury, which are quite unique and different from the general population. And so all except for the two in red, the big two we talked about, having low hip or knee region bone mineral density or prior fracture, are just things people can obtain from history. So you don't need to be a rocket scientist to apply them. You could fill it out yourself and take it into your therapist or your family doctor to talk about. So we want to know if people have had a hip fracture in the last year, or any direct family member has a history of hip or wrist fracture. So if you have a direct relative, your parent, your sibling who's had a hip or a wrist fracture, that's what we're talking about when we say family history of fracture. If you personally have an alcohol intake of greater than 5 servings per day. If you have paraplegia, motor complete injury, so that's the people who are ASIA impairment scale A or B. If you've had your spinal cord injury for more than 10 years, if you routinely take benzodiazepines, so that's things like lorazepam, Ativan, clonazepam. If you take anticonvulsants, particularly gabapentin or pregabalin, or you routinely use opioids at greater than 28 milligrams of morphine for a 3-month period, these are independent risk factors for fracture. So what does this tell you? It tells you if you're on benzodiazepines or gabapentinoids long-term or opioids, you need to think about, can you get to the minimum effective dose to reduce your fracture risk? But these are the risk factors that are common in the spinal cord injury population. Ideally, your clinician should be reviewing with you these risk factors annually. And anytime that you have a functional change in your abilities, or let's say you've had a minor injury after a fall, or say you've been unwell, you had pneumonia, you've been in bed for 3 months, this would be a time to also do that. And then the ISCD position is recommending that everyone with the spinal cord injury get a bone mineral density test done after their injury. Okay. When you look at Jordan, the case that we presented, this would be an example of Jordan's risk factors that we might commonly see, and to look at what's modifiable or not modifiable. So when we look at Jordan, he's an opioid user, so that's a risk factor that we would try to modify and see if we could wean him off the opioids if possible. He has a traumatic spinal cord injury. He's motor complete, and his injury duration when you meet him is not very long, so that's not concerning, but for many people have an injury duration of more than 10 years. And then you look at the knee region bone density and see, is it high or low? And if it's low, we have some values below which, if it's that low, we would say your fracture risk is high. And then usually we would work with the person to try to modify the modifiable risk factors like smoking, alcohol, some of the medication use. The non-modifiable ones you can't change, but you just need to be aware of them. So after discussing with Jordan his goals and interests and his fracture risk, we would talk to him about his fracture risk and then provide an exercise prescription. Anita, if you could go to the next slide, that'd be great. So one of the things Jordan might want to consider is passive standing for 1 hour, 5 times a week, which early after injury for the first 2 years can prevent bone mineral density decline at the hip and knee region. So you have to have access to the equipment and have a lot of time to do this one. But if people have the resources to purchase a stander or have access to a standing frame, once a week, 5 times a week, can help to maintain bone mineral density and prevent osteoporosis onset. And then there's also the opportunity of doing lower extremity muscle activated and load bearing rehab therapy. So FES or NMES for at least 1 year does help to prevent osteoporosis onset. There are lots of other benefits of standing that aren't really covered in the CPG, like people feel better, they have better self-esteem, they have better transit time, they feel like they've had a chance to really stretch out their trunk and their hips, and they enjoy being upright and looking people in the eye. But what we're talking about here is just the improvements in bone mineral density that we're really talking about today. So you need to do it 5 times a week for at least an hour for the first 2 years after injury to prevent bone density decline. But if you do it less often, you'll get other therapeutic benefits, but it won't be bone. Next slide. In terms of functional electrical stimulation or NMES, in BC and Alberta, there are lots of people doing FES and NMES regularly in some of the gym programs. So we want to make sure that you have a visibly strong muscle contraction from the electrical stimulation. And we know that with specific pulse duration frequencies of 20 to 33 hertz and amplitudes up to 140 milliamps, that people will see improvements in bone. But we sometimes have to start at lower frequencies and pulse durations, and then sort of gradually work ourselves up to this so we can actually produce changes in bone. So I don't know if you know, but recently there's literature showing that muscle and bone talk to each other. And then when you have healthy muscle from the exercise, that does stimulate healthy bone. So when you're doing FES or NMES, you're trying to do that for 30 minutes, 3 to 5 days per week. There's some nuances in the literature about how much benefit you get, but at least 3 times a week, you will see some therapeutic benefit. Next slide.
Okay, so I can take it from here. So basically, we're just going to touch on briefly a bit of information from episode 5, which talks about the benefits of vitamin D and calcium. So your body needs vitamin D in order to absorb calcium, but there is an increased prevalence of vitamin D deficiency in the spinal cord population. And vitamin D is not found in many foods, so supplements aren't often needed. Your body can make vitamin D from direct sunlight on the skin, but depending on the weather, the time of the year, the time of day, as well as your skin color, could impact the amount of vitamin D that your body's able to make. So our recommendation is usually in the range of about 1,000 to 2,000 international units per day of vitamin D as a supplement. And you should be getting your vitamin D levels checked yearly to make sure they're sitting at least the level of 80 nanomoles per liter. In terms of calcium, the chart there at the top shows what the recommended daily intake of calcium is, depending on your age as well as your sex. There's also a link to a calculator. There's a lot of, there's many sources of dietary calcium, and it's always recommended to try to get as much of your recommended daily intake of calcium through diet as opposed to relying on supplements. And that link will take you to a calculator where you can calculate and estimate the amount of dietary calcium that you're getting, and then you can always top up to the recommended dose through supplements. This also helps to reduce your risk of getting stones. However, if you are at high risk or do experience bladder and kidney stones, they usually consider and recommend a lower dose of calcium in the range of 750 to 1,000 milligrams per day. And again, trying to aim to get that calcium source through foods as opposed to supplements. Okay, we're going to take you to another case study. We're going back to Jordan now, but he's now in the chronic stage of his injury. And in this case, Jordan is now 48 years old with T8 Asia A paraplegia from 12 years ago. He had a venous thrombosis embolism, which is a blood clot, during inpatient rehab, and he comes to the physio clinic reporting swelling on his right shin. He fell playing wheelchair basketball 2 days ago, and he has a low-grade fever today. So I'd like you to think about what you think is concerning, and just from your own basic knowledge, what it is that you would advise. And again, you can put your thoughts and ideas in the chat. This information could be found in episode 8 of our podcast, which is Snap and Crack. I'm not going to play the episode for you, but I will pass it back to Dr. Craven, and she can cover some of the key concepts that you'll find.
So what do people think? What would you think about the person with the swollen leg and a little bit of fever? What are the things that come to your mind?
Well, he fell, so he should have had himself checked right away.
Awesome. If you remember nothing else from today, please remember this. So what could that swollen red leg be other than a fracture? Anybody?
I mean, he could have burst a blood vessel. He could have, there's all sorts of things it could have been, but most likely it's probably a fracture.
So it could be a fracture, it could be a blood clot. He could have a cellulitis that he just needs a little antibiotic therapy. So there's lots of different causes, but the biggest thing that we want you to remember is to go and be seen and get an x-ray. So many times patients show up days after and it's very hard to intervene. And if it is a blood clot, it is life-threatening because it can move from your leg up into your lungs or your heart. So, if you see that red swollen leg of unclear cause, you need to get it evaluated. And yes, that is that painful time in the emergency room that nobody wants to do, but fracture is one of the few things that this is where being in the ED is a good place to be. So will everyone try to remember that's the one thing we'd like you to take away from today. This section is just going to talk to you a little bit about conservative versus operative fracture healing. Some things to think about in terms of maintaining your functional independence when you're recovering from a fracture and how to prevent blood clot. Next slide. So like I said, the biggest thing we want you to remember is to get an x-ray. There's lots of different reasons why you could have a red swollen leg. Could be a pressure injury, could be heterotopic ossification, could be cellulitis, could be a fracture, could be a blood clot. And all we need is simple things that any idiot doctor can do, getting an x-ray, getting a blood test, and we can tell you. So these are not complicated things, but it's really important if you do have a fracture that you actually undergo orthopedic consultation. Last year in 2023, we published new guidelines from the Orthopedic Trauma Association about how fractures should be managed after spinal cord injury to try to promote healing and prevent people from having long-term complications of fracture. And also, anytime you have a fracture, we want you and your care team to revisit this whole paradigm that's outlined in the CPG, which is going through your medication history, your non-BMD risk factors for fracture and falls, doing some laboratory screening, diagnostic imaging, assessing your fracture risk, trying to optimize your dietary calcium and vitamin D, and then exploring the role of therapy and increasing your bone mass and reducing your fracture risk. So when you have a fracture is an important time to re-engage with the healthcare system and try to optimize your care, because as we know, one prior fracture contributes to future fracture, right? Okay, next slide. When you have a fracture, there's a whole debate about whether your fracture should be managed with surgery or conservative management. And in our new position statement, we really recommend shared decision making, where you as a patient and the surgeon weigh the risks and benefits of surgical versus conservative care. Also looking at your values, preferences, health status, medical comorbidities, and the availability of family or attendant care resources. If you have a lot of medical comorbidity, you might like to go with conservative management and a cast, but then you'll likely need extra help from your family or attendants, because often these conservatively managed fractures will take 3 or 4 months to heal. So it's not like you're getting a cast for a few days, you're signing up for a couple of months of immobility and needing extra help. If you're somebody who doesn't have a lot of help at home and you're really healthy, you might opt for the surgical intervention, so you get the intervention done and then you can carry on with your life. In general, we recommend that the fractures above the knee be managed operatively and the ones below the knee be managed non-operatively, and that's kind of like a golden rule. But this is sort of changing now, and it has to be really a dialogue between you and the surgeon. Next slide. The other thing is, when you have a fracture now, we also recommend that once you've had sort of definitive fracture management, they've decided you have a fracture and you need a cast, or you've had a fracture and you need surgery, that VTE prophylaxis, or preventing a blood clot, is initiated. And this can be done through low molecular weight heparin, which is a daily injection, which you would typically get in hospital. Or you can get a direct oral anticoagulant, which is just a pill that you can take 1 a day to try to prevent blood clots. And we want people, as soon as feasible, to start getting their medication to prevent a blood clot. So what should you remember from this? Get an x-ray and ask the surgeon or the treating physician, hey, do I need a blood clot prevention? Those are the 2 questions you'd like to ask. And we're recommending that people continue this for at least 2 to 4 weeks, or when you return to your premorbid mobility. So if you're somebody who's incomplete and normally walks a little bit in the home and uses a wheelchair outside the home, it might be longer. You might need, 8 weeks of prevention, because it'll take you a while to get back to your regular mobility once you get your cast off. If you're somebody who's normally in a manual wheelchair and you get back up in your wheelchair, it could be as short as 2 weeks. But preventing blood clots is an important part of the picture. Next slide. We recommend, when you come to osteoporosis clinic, that all patients, so both adult men and women, undergo serum screening to look for, are there any other reasons why you might have low bone density that's not related to your spinal cord injury? We like to blame everything on your spinal cord injury. But when we do this very simple lab screening that your family doctor or nurse practitioner can do for you, or your physiatrist, 1 in 3 people typically have a reason that we can modify to help improve their bone mass. So this simple lab screening is a really great way to try to optimize your bone health. Something for you to remember. It's something you can do when you go for your annual checkup with your family doctor. Next slide. For some people, there's some extended testing that is recommended in the CPG. So anyone over 50 who has a vertebral compression fracture, we want to make sure that we've screened for with a protein electrophoresis, and screen them for myeloma or a form of bone cancer. And people with Cushing's or celiac disease, or special tests related to that. And we sort of given guidelines to your doctor about when you need to see other specialists. So when you need to see an endocrinologist, a specialist in nephrology if you have ongoing kidney problems, or if on the blood screening you have a monoclonal gammopathy or one abnormal protein spike on your serum protein electrophoresis. So these are sort of criteria to help your family doctor or a general practitioner know when to make a referral. So you don't need to know about that. You really need to know about the screening on the previous slide. Next slide.
Okay, I'm just watching our time, but we're almost at the end, so I'll just get through these last few quickly. We just wanted to sort of touch on the co-design approach we used and just share some of the few things that we learned through working on this project. So one of the things is that we did recognize that podcasts are a popular way to learn, but we did know that it was really important that the resources that we used came from trustworthy sources, and that's one of the key reasons why we use the CPG guidelines. And we also recognize that it was really important that the information was provided in a simplified way so that people with SCI would be able to understand the information provided and also find it important and interesting and be able to know what to do in order to improve their health. We also tried to find a good balance between the level of detail that we provided, which is a bit tricky, you know, providing enough but not too much detail that you sort of got overwhelmed by it, and also being able to provide it in a number of formats. So both audio and video for the podcast, as well as providing the handout tools. So you're sort of catering to both the audio and visual learners. So in conclusion, you know, the podcast and the handouts we hope will aid you as well as your family caregivers to be able to advocate for ongoing bone health assessments and be able to promote dialogue with your care team regarding fracture prevention. We also hope it'll be able to empower you to act to improve your bone health and reduce the fracture risk, and really think about some of those key points that Dr. Craven brought up during this talk. And just a reminder again that the podcast and the handouts are all available on our website. So please go in, have a look, share it with your healthcare team, and help us to get the word out for it. I just want to acknowledge the other members of the team that were really instrumental in helping us to develop the podcast series and the handouts, as well as acknowledge all of our guest speakers who, like I said, were authors on the PVA CPG guidelines. And of course, all of our funders who would not, where, you know, this wouldn't have been possible without their support and assistance. And I think that's it.
Okay, I will take over from there and just say thank you very, very much. Very detailed. I want you to know that most of the people on this call have had their injuries for a long time. Not all, but a lot of them have had their injuries for a long, long time. So some of the stuff that you've gone over, we've heard. I'm wondering, I get people have questions. I think, Debbie, do you have a question or are you just saying great?
Great.
Okay.
Trying to get the
Okay.
thumbs off now.
I'm wondering, I have to say, I've been in a chair for 50 years and I actually broke my leg twice. The first time was, oh, I don't even know, probably 30 years ago. And I was lucky because I got an orthopedic surgeon who basically went through all the implications of both types of management. In that he went over, if I tried to do it surgically, your bones might still be a little bit brittle. He didn't do a test though. The whole bone density test thing it's basically new to me. I know that you can do it, but I didn't know that physicians were well aware of it and should almost be recommending it. And is that the case? Is that the case that physicians
Yeah.
have been informed and should be recommending this?
Yep. So in 2019, we published the position statement that everybody with a spinal cord injury should get a bone density as early as possible after their spinal cord injury, and then at least annually during the time period when you have that really rapid drop in bone density. And then as you stabilize and go out over time, maybe at every 2 to 3 years after that. In some centers, that's happening routinely, like we do in Toronto. In other centers, it's not, but we've been working very hard to try to get people to implement this standard.
Okay, good, good. That's great to know. Anybody else have questions? I know I have more, but does anybody else have more? Anything they really, I know that we asked, is there a difference between men and women? And I know in some of the slides it was identified as simple, but I'd like you to just explain a little bit about
Well,
that.
if you look at bone loss after spinal cord injury, men and women are equally affected. So what women have as an extra challenge is the bone loss that happens associated with menopause. So if you're a young person, let's say you're 40 at the time of your spinal cord injury, you'll have spinal cord related bone loss. And then you might, have a child go on and go through menopause. And then at menopause, women will have another decline in bone density related to hormone withdrawal. And so we understand this better and we can map it better. Men do get some age-related decline in bone density that we call andropause. It's not true menopause. It's not the same severity, but men do get a little bit of an uptick in bone loss as you cross age 60. But it seems like the spinal cord injury talks much louder than the person's sex in terms of how it impacts bone. The extent of bone loss, the pattern of bone loss are similar in men and women, and the therapies that we have right now seem to work to the same extent in both groups.
And I think we asked, and you might have actually gone over it in the presentation, but it sounds like we should all be asking our physiatrist for this bone density screening.
Yeah.
And then the amount of times we should do it. That was the question. I think every year, or I can't remember.
Well, annually in the first 2 years after injury. So if somebody just is newly injured, right when they're in rehab, and then a year later and a year after that. But if you get out to your many years post-injury, it could be every 2 to 3 years.
Okay.
Because
Okay.
bone loss sort of stabilizes.
Okay, and then there's something in the chat. Megan put something in the chat. I saw it.
It says,
Yeah,
can you speak to why gabapentin, opioids, etc., increase risk factor for osteoporosis? Is it directly related to something in the drugs or indirectly from falls risk?
Great question. For opioids, it's actually how it affects the bone. For gabapentin, as opposed to other anticonvulsants, it may be the drowsiness associated with its impact on your mobility. That's a little bit of not totally clear yet. So if you were taking something like lithium for preventing seizure or bipolar disorder, that has direct effects on bone, but the gabapentinoids, it's not clear. We do know that gabapentin early after injury can help with neurologic recovery, and it's a great medication for managing pain if you have long-term neuropathic pain. But this is just something new that's come out in the literature from analysis of the VA data, their health administrative data, so very large sample size, showing that gabapentin and other anticonvulsants may have adverse effects on bone.
There was also a comment from Ross, who said after 2 femur fractures 6 years ago, BMD and Prolia injections, what is the generic version of Prolia? An extended health provider will no longer support Prolia.
So in November of 2024, the government approved Jubbonti, which is a bioidentical medication to Prolia. In Toronto, we have been using Prolia for treatment of low bone mass and high fracture risk for a long time, more than 10 years, and we're actually in the process of writing up our results right now. We assume, but we don't know, that the side effects of the bioidentical Jubbonti will be the same. We have no data about this. I actually think Health Canada forcing everyone to switch is problematic.
What do you spell that?
But if your choice is nothing or Jubbonti, I would probably try the Jubbonti. And, if you're having side effects, then you could apply to the special access program to get access to Prolia instead of Jubbonti.
What do you spell Jubbonti?
Jubbonti. I can put it in the chat.
Okay, thank you.
There is one other bioidentical that I can't think of the name of it right now. In Ontario, the Ontario government has funded Jubbonti. I think it's different across the provinces. So there are two bioidenticals for Prolia. Let me see if I can look them up here. I just can't remember the name of it right this second. But we've just been having a long conversation with people about this, that we don't know as much, and even with the estrogen bioidenticals, it's complicated. Xgeva is the other one. Xgeva and Jubbonti.
I think it was Jubbonti. I was told about.
Okay.
Okay.
Yeah.
Thank you.
Anybody else have another? Ross, have you got another question?
No, I have polio, so I had no trouble feeling the fractures.
Yeah.
And they were a year apart, and I both from falls. And I was told that by one of the hospital physicians that they're at least one of them was considered what he called, I think, pathological, because the nature of
Yeah.
the fall should not have broken the bone.
Yeah.
And because I've had polio since I was 1950.
So in people with polio or neuromuscular disease like Duchenne muscular dystrophy or spinal muscular atrophy, the bisphosphonates have actually been shown to not only bisphosphonates and anti-resorptive medications not only help reduce your fracture risk, but they've actually been shown to extend your longevity and reduce mortality. So in people who are non-spinal cord injury population, there's actually quite a bit of literature about the drugs being good.
Okay. Gordon, you've raised your hand.
Yeah, this can't be better timing. I had a bone scan in December, and I've been diagnosed with osteoporosis. I did talk with my physiatrist when I met him at the beginning of March. However, he suggested that I probably deal more with my GP, which happened to retire at the end of February. So do they have any like osteoporosis clinics or anything like that within the hospitals that I can go and talk to them?
Every city has osteoporosis clinics. Not everyone is good at managing osteoporosis after spinal cord injury, but every city has an osteoporosis clinic. If you're not sure, you can reach out to Osteoporosis Canada. There's 3 drugs that have been shown to be of some benefit in spinal cord injury. So oral alendronate, which is a drug called Fosamax. There is intravenous zoledronic acid. So that's a IV preparation. You get an IV put in, you run it in, you get 1 dose once a year. So it's kind of appealing because you get it and then you're good for the year. But you still have to take calcium and vitamin D. So calcium in your diet and vitamin D supplements, plus the IV therapy. So IV zoledronic acid is really great, except for people who have a kidney problem. So if you don't have kidney problems, IV zoledronic acid is kind of appealing. And then Prolia comes as a subcutaneous injection once every 6 months. What's great about it is you need to have the first dose in a clinic done by a nurse or a doctor. But after that, a visiting nurse or your pharmacist can give you the injection. But it does need to be given very strictly at 6-month intervals.
Yeah, I live in long-term care, so are the LPNs and RNs, you're able to administer it?
Yep. Yep. It's just that somebody's going to watch you to make sure you don't have a reaction after the first dose.
Dr. Craven.
Sorry.
Go ahead.
I also do the exercises. I have 20 minutes on my arms and 20 minutes on my legs 3 times a week. But
awesome.
they canceled my tilt table.
Yeah.
And they said it wasn't a good idea with osteoporosis to weight bear, and yet you're saying the opposite.
Yeah, so it's riskier, and they need to explain to you that you have risk of doing it, but it's of therapeutic benefit. So you can explain to them that you understand that it's risky, because nothing in the guidelines are saying don't do it. It's just saying making sure that patients understand if you have low bone density and you're doing specific activities, you may be more likely to fracture than someone who has a normal bone density. ISCD position 4 is the one that says don't prevent people from doing activity, just explain to them their fracture risk. I can put a link in the chat if you just give me 1 second. So this is an important part, is that we don't want people to overgeneralize and be preventing people from doing activity. What we want them to do is consent you to make sure you understand what's risky and what's not. So, and there's good evidence that, the standing can actually be beneficial. So,
Okay, so that's in the chat room now, Gordon.
Yes, I've just downloaded it, so.
Okay. And I have a
Okay.
quick question in terms of, you said there's
No.
a osteoporosis clinic in all cities. Now you're from Ontario.
yeah.
And we are from BC. Is that in all cities nationwide or just provincially?
Well, osteoporosis in general, there's osteoporosis clinics all over the country
Okay.
that are run by rheumatology, endocrinology, sometimes physiatry.
Mm-hmm.
And bone health and spinal cord injury clinics are less common. So
Okay.
I have had one in Toronto for 20 plus years, but we have been teaching centers across the country and across North America and even in Europe how to do the bone density testing, how to set up their clinic.
Do you know if there's one at Blessum or at GF Strong in BC?
Well, I did a research study with Dr. Krasikoff a couple years ago, looking at comparing arm ergometry and treadmill training.
Mm-hmm.
One of the outcomes from that study was bone mineral density, and I did teach them how to do the knee region bone density at that time. So I believe there's capacities at GF Strong and the hospital that's attached. I'm sorry if my brain is shorting out.
Vancouver Coastal.
Vancouver Coastal Health, thank you. I believe they have the capacity to do it.
So we would ask a physiatrist out here, probably.
Probably, but there should be general rheumatology or endocrinology clinics. If you ask your family doctor, can I go see an osteoporosis specialist? They should be able to find you one. There's lots of them.
Okay.
Even
Duncan,
in
there's
the
a few
far north.
questions before she goes.
Okay,
There's a few
well, let's
questions
get
in
to
the
them
chat.
quick.
There we go. Hi.
There you go.
I have a question, and that is that, basically, I'm in Vancouver, BC. I've had an injury 33 years, and nobody has helped me at all. And so now I'm just finding out I'm going to see Dr. K. And if that doesn't work out in Vancouver, where can you go, or do you have to go out of Canada to get help?
No.
I have osteoporosis, like you wouldn't believe. It's taken out my bones and everything. And, I just don't know what to do. I'm just asking that.
I think
There's lots of very good bone metabolism doctors across Canada. And if there's a doctor in Canada that doesn't know what to do, they can always reach out to me.
Yeah, and Dr. K should be able to refer you to somebody. He might not be able to handle it himself, but he may be able to refer you to somebody.
I'm praying for it. Thank you so much.
Okay. Anybody else?
Dr. Townsend, Dr. Wilms, all of them. Yeah.
Okay.
I did want to answer one question,
Well,
if
okay,
it's
go
okay.
ahead.
There was a question about, does the use of antibiotics such as Cipro have an effect?
Oh, that's right. That was from
So
Paul.
Cipro has been shown to have an adverse effect on arthritis. That's the disease that happens when you grind together the cartilage on the end of bone. But Cipro does not have any effect on osteoporosis changes in the bone structure inside the bone.
Okay, great to know. And yes, thank you I should have remembered that.
It's okay. I just had the list here, so I just want to make sure we covered them all.
Okay, Joan, do you have another question? No? Okay. I will let you guys, I want to thank you very, very much. It was excellent, fantastic.
Whole purpose of this was to share and have people look, and please, if you don't like a section or you have feedback, please use that evaluation button. For us, we're, keen to get feedback from people and to sort of revisit and revise these over time.
I just got
We're
another.
also working on a menopause series. So hopefully a year from now, we will have a series on menopause for women as well.
Okay, and then there's a note in the chat box. There is an osteoporosis clinic at BC Women's Hospital, St. Paul's Hospital, and another few private clinics. So somebody in our audience already knew. Okay, great. Okay, thank you again. It's fantastic. Thank you very, very much.